Hello, my name is Tekla Dureburu. I am a nursing student at the Midwestern State University. I'll be discussing prevention of court review of indication for indwelling urethral catheter. This is in fulfillment of my Capstone project. This presentation is of the burden of COTI and the role daily catheter review plays in the prevention. I'll be presenting data the use of this method, and then I'll be talking about the challenges that arise in the implementation of this method and how to mitigate it. First, catheter-associated urinary tract infection occurs when pathogens enter the body through the This contributes to healthcare-associated infections, which cause diseases, prolonged hospital stays, hospital cost. A daily review of the necessity for the use of the urethral catheter is a form of infection prevention, therefore invariably improves patient outcome. Daily review of the indication for the urethral catheter increases prompt removal, therefore limiting exposure of the patient to cutting. With a reduced risk of catheter-associated urinary tract infection, antibiotics is reduced, as well as the risk of antibiotic resistance. Patient recovery time decreases and patient outcomes. COTI contributes 36% care-associated infection, as well as 70 to 80% of UTIs, which are caused by the presence of a urinary catheter. In other figures, the prolonged use of a urinary catheter should be reduced, and this can be achieved by the daily review of the indication for the use. Removal. My problem statement is in hospitalized adult patients with indwelling urethral catheters. A review of the indication for continued catheter use compared to standard catheter care practices without routine daily the incidence of catheter-associated urinary tract infections during their hospital stay, which is comparing between the use of daily assessment of prevention of COTI. We'll go ahead and discuss the data that I have found in the for the urethral catheter as a method of prevention of COTI. The CDC published in 1980 guidelines for the prevention of COTI. It was updated in 2009. These guidelines still apply today in various hospitals. They include prompt removal of catheters, and this can only be achieved if you are able to assess for the need of the catheter. They also developed targeted assessment for prevention (TAP) strategy to prevent healthcare-associated infections such as COTI, CLAP, other types of hospital-acquired infections. The research done by Hernandez et al. showed that using a checklist to decision for catheter makes it easier to detect when the use of the catheter no longer applies and therefore the need for removal. The same with the research done by Mersglod et al. They used a checklist as well to determine the removal of urethral catheters in the hospital. And they found that when the nurses adhered to the checklist and completed it, improvement in the removal of urethral catheter and therefore the decrease in cutting. Another research focused on a bundle which included daily review of necessity, hand hygiene, insertion skill, and with some of the bundle, there was reduced cutting in the research patients. Talk about prevention of the disease without involving multidisciplinary approach. It is, although nurses are the primary caregivers, doctors and other health care staff have the responsibility of taking charge of the patient as well. And so medicine talked about the multidisciplinary approach in helping to reduce the cutting in the hospital. Their study was also reiterated by Gupta et al. In 2023, where they used the multidisciplinary strategy to cardiac ICU. This approach was done by daily assessment of the need for catheter and implemented by the team. The article by Value et al. In 2021 talks about the challenge that affect cutting prevention using the daily assessment. He mentioned the high workloads in some areas, inadequate between staff. These are some of the gaps that make it difficult for the daily assessment of the catheter use to prevention of clotting. It was also described in the article by Plando and his cohorts that it takes it among healthcare workers to achieve the prevention of cutting, especially in daily assessment. That the use of urinary catheter increases patients' risk of cutting by 3 to 7% every day that it. My proposal is to reduce the incidence of cutting in hospitalized adult patients that require the use of urethral catheter. This will help prevent diseases, it will help reduce the hospital stays, it will help reduce hospital bills, and also improve patient outcome. As I've mentioned, I am proposing that the daily review of the necessity of the urethra be used in the prevention of clotting to prompt the removal of the urethral catheter if it is no longer needed. And with the absence of urethral catheter, it reduces the risk of getting into the body. This plan will be implemented by nurses in collaboration with other healthcare teams. It is also imperative that hospital management strive to improve productivity as well as patient safety and outcome by improving standard protocols, daily review of necessity of the urethral catheter in these standard protocols. The prevention of the imputes of all healthcare workers. It involves educating the stakeholders, which is nurses, which are doctors, well as patients and hospital management about this new standard and the evidence-based practice results that are available. First of all, a handoff checklist that includes the daily review of the necessity of the urethral catheter can be used. For instance, you can use a checklist during nurse-to-nurse handover during rounds in order to determine if this patient needs the continual use of the urethral catheter. There should be standardized development and integration of clear guidelines so that nobody is confused of what the plan of care is. It requires a disciplinary approach by incorporating catheter necessity checks into daily rounds, where nurses are able to tell the doctors this for this urethral catheter being around. We are no longer doing, for instance, hourly urine output documentation. Patient work with the physiotherapist and is able to get out of the bed and use the bedside commode. The patient is able to use other forms of mechanisms to collect the urinal, or we can use the PureWick as well. Protocols should be designed to empower nurses to without direct physician orders when patients no longer meet necessity criteria. For example, in the orders given to nurses, it should read something like and remove the catheter when it is no longer deemed necessary. In this case, the nurse is able to determine through her assessment that the patient doesn't need it and removes it as the need arises, and not have to wait for an explicit order that says to remove the catheter, which will prolong. Electronic alerts in the EMR. This prompt nurses to document their assessment why the catheter is still in place or needs for removal. There should be routine education and training to all clinical staff about clotting and know the diseases, the consequences of the urethral catheter being in place. They will understand the need. There should be compliance with daily reviews, and catheter removal protocols should be monitored through regular audits. COTI prevention bond daily reviews to prompt removal of these catheters. Patients and families should also be educated about the risks associated with the unit, because sometimes the patient is able to say after education, I do not need this. Can this be removed? And that's for removal. Now let's talk about barriers to this implementation. Availability of resources such as educational campaigns may cost time and cost money. Um, Patient to nurse ratio, therefore, we do not have enough nurses, and therefore the rate at which this assessment is being done, and if it is being done properly, a challenge. Compliance to change. Some people are stuck in the old ways, and in this case, they might need more reasons, evidence as to show them what what should be done at this moment to be able to reduce the incidence of cutting. There is bureaucracy in developing organization protocol, which means that sometimes there are evidence which is acceptable, but because there is one person to sign off on something and another body that has to sign off on the other, this makes it takes time, and this people face in order to bring about a change. Just like before, the high workloads, the limit the time for thorough nursing, as miscommunication among multidisciplinary teams where um, the nurses are not able to communicate to the doctors is no longer necessary, or the doctors are not able to communicate, vice versa. But there is a gap in communication, which puts the patient at risk of clot. Omission of discussions regarding daily catheter need during rounds and during nursing handoffs. And this can be mitigated by continually, even daily assessment. If it is missed in the morning or in the evening during the nursing handoff, the EMR can prompt the nurse, uh, do an assessment and document it. Evaluation of this method of prevention of clotting. Their measures include conducting a baseline assessment of patient outcomes using the previous standards. So you take an assessment of what is already happening so that when the strategy, which is daily assessment, is implemented, you are able to compare the result to the previous standards. Tracking COTI incidence rates before and after implementing um, assessment. Procedure measures including monitoring compliance, staff feedback by survey to satisfaction and identify the challenges. Cost analysis. Everything is money intensive sometimes, and you can compare what is the reason right now, what is the cost of having this patient on a catheter Foley and risking COTI, and then if this patient is on with using the urethral catheter, and how much is that costing the patient at this time? This proposal of daily review can be discussed during meetings and presentations such as this one, as well as unit-based meetings, as well as hospital nursing association meeting conferences. We're making sure we can also use online strategies such as webinars, disseminate information. With staff training, we have what we have called acquisition, and during that, you can talk about this new strategy of preventing COTI. leadership buy-in. You can present it to the hospital leadership, and this will to to come up with a standard protocol that is acceptable to be used in the hospital. You can use educational materials such as brochures to teach, and then it can be placed in the EMR to send alerts and reminders to nurses to make this assessment. You can have the audit report to find out what's going on, what is what is better, what should we change in order to bring about the success of this method of prevention. In conclusion, prevention of COT is important in improving patient outcome and reducing healthcare associated infection. We can do this by assessment of the urethral catheter necessity to prompt removal and reduce disease. This practice will need the as well as interdisciplinary collaboration. Here's the list of my references. My images are from google.com. Thank you so much for my presentation. I thoroughly enjoyed it, and I hope that you did. And I hope that you will also be implementing this strategy while taking care of your patient. Thank you.